Good afternoon and welcome to the current breast cancer Q&A webinar. We had a different agenda originally for this one, but we had to make some changes because of we were going to have someone join us who was not available. But you have me again, Dennis Holmes and Sharon. You want to start?
And she'll probably be with us the next one in May.
Okay, thank you. But we decided to welcome some new questions and maybe recap a few old ones that Sharon thought was important. So why don't we get underway?
Okay, the first one I have for you is, what was the inspiration for you becoming a breast-only surgeon?
Oh,
Since
wow.
all the ladies are always asking me if anybody in your family or something.
Yeah, it was kind of a journey. You know, I started off with an interest in vascular surgery, blood vessel surgery. I'll just give you a little backstory about that. When I was a kid, my best friend was an older woman who had peripheral vascular problems. She had issues with walking and due to low blood flow. And so my original training and my years of research was initially committed to vascular surgery. I was going to be a vascular surgeon. And then while I was in the midst of my training to become a vascular surgeon, I had several cancer diagnoses occur in my family. My dad, my mom had a benign brain tumor, and my partner had thyroid cancer that eventually became metastatic and fatal. But in the midst of my time sort of training to be a vascular surgeon, I kind of had to redirect completely. I ended up putting a halt to my training. I dealt with oncology full time and, you know, all in one to 2 year period. And there was a time when I sort of had to kind of think about my life, like what I was going to be, reevaluate my life. And as I was talking about my own personal cancer experiences, just kind of casually, I would constantly hear people saying, oh, my friend, my mom, my dad. It's like everyone had some experience with cancer. And I didn't realize up until that point that it was just such a prevalent disease, that cancer was such a prevalent. I mean, I knew it intellectually, but it's different when everyone you know can tell you one or two stories about
and it's
someone.
A lot worse now.
And it's a lot worse now. So one day I was at the gym training with a personal trainer. It was just a moment that it just happened. I was training with a personal trainer, and we're just having a casual conversation about things that are happening in the world. And she said to me, "Did you hear Dusty Springfield just died of breast cancer?" And it was just like the camel that broke the straw that broke the camel's back. It's like, someone should do something about this. That was the moment when it happened. I know nothing about Dusty Springfield, just one or two songs. It was not that she was a really important character to me, but that event is what crystallized this. And so I basically decided that moment that I was going to redirect my training and from vascular surgery to oncology. And when I resumed training, I had the opportunity to work with someone who was a breast specialist. I didn't sort of intentionally work with him, but he was a person with whom I was working, training at the time. And I got to interact with him. I also got to interact with his patients. And it was that experience of kind of caring for patients with this problem, lots of women, lots of young women, you know, a very curable cancer, but needed the right treatments, a very curable cancer, but with lots of burdensome treatments. I saw that it was kind of a place for me to sort of thrive. And so I thank him, is James Harness. He's a practicing surgeon, actually maybe recently retired, who kind of helped to focus my interest in oncology and specifically in breast oncology.
And a lot of us are glad you did.
Well, you look at these experiences as sort of a negative, but often the negatives are positives. And so I see the silver lining in my own family's, crisis, because it helped me find a new purpose. And that's, paying dividends to others, I think.
Well, it was a positive thing for me too, even though people don't think it is. It's been really a positive experience. How long have you been doing cryoablation?
Well, as you may have heard separately, when I, one thing that drew me to breast oncology is that in interacting with patients, I recognized we had some reasonably effective treatments, but a lot of the treatments were quite burdensome to
Mhm.
patients, that patients did not want to have the treatment because the treatment they perceived was worse than the diagnosis.
Mhm.
And so it sort of made me think from the very beginning, okay, what can we do to improve the delivery of cancer care, to offer treatments that are effective, but that are less burdensome than traditional? Because we don't want people to kind of delay diagnosis, to delay treatment because they fear the treatment. And only to allow their cancers to grow. And I saw that many times. I still see it today, but I saw it, I recognized it as a real problem early on. And so when I was in training, I went to a meeting, one of our annual breast cancer meetings, and someone presented cryoablation as a new way of treating benign breast tumors. That's the only thing for which it was approved at the time. But I decided, I recognize that, maybe they're talking about using this for benign breast tumors, but I see the possibility of this being used as an alternative to surgery for cancers.
Mhm.
It was still like, 8 or 10 years before it was studied in that way, but I recognized that ability. And so I started to learn how to do it. I started to treat benign breast tumors, not because I had any interest in treating fibrinomas, but I knew that one day we would get there. I would be involved in research to get us there, and I needed to learn how to do it. And so, in 2003, I began the process of performing cryoablation and did so for the first 6 years only on benign tumors. And it wasn't until 2009, as a part of a trial, that I started to offer it to cancer patients.
Yes. My doctor said that cryoablation is for older people and smaller tumors. Is this true?
Well, it's partly true. Kind of in the ideal use of cryoablation, the way that it was conceived as a treatment for small tumors. Not necessarily old patients, but for small tumors. Because the device itself is capable of freezing a limited volume of tissue.
Mhm.
And so the tumor has to fit well within that space. So if you think of the typical freeze volume of being the size of a walnut, then you need to have a cancer the size of,
Great.
a grape. Right, it's a good example. For it to fit well within that space. Now, as you know, we can overlap multiple treatments to treat a larger volume of tissue, but the ideal example, scenario for cryoablation is to treat a tumor the size of a grape or smaller with an area that freezes about the size of a walnut, so that you have a natural rim of ablated tissue around it, a margin around it. So that's kind of where, it's most likely to be used in the future. That's where it's been predominantly used within trials up to date. Of course, we treat larger patients, but the ideal patient being that one. The other idea was that, it's ideally used in a patient that does not need to have lymph node surgery, is ideally used in a patient that does not need to have radiotherapy. And so it so happens that older patients tend not to need radiotherapy, tend not to need a lymph node biopsy. And so it's kind of perfect for them. But there are younger women, or people that are not necessarily, I would say, old women, that may have a situation where they either don't need lymph node surgery or refuse lymph node surgery, or they don't need radiotherapy because they have a low risk tumor, or they refuse radiotherapy. So cryoablation still has a role for a broader set of patients, not just the old women. And we're learning how to kind of choose the right patients for it now.
But you've still frozen tumors and then the next day or the day before done a lymph node surgery as well.
Yes, it
So
doesn't.
you still have that option.
Right. And so that's why I say we're still trying to figure out how to integrate the other components of therapy in a patient that opts to have cryoablation for her breast, maybe for cosmetic reasons, maybe because for other reasons, but it is still a way of dealing with the breast cancer without having any, or with having minimal impact on the breast shape and appearance. But that patient, if she has a high risk tumor, or if she has a positive node, she still needs to have some lymph node therapy. And so just because you're doing cryoablation of the breast doesn't mean that the patient is not entitled to have the proper management for lymph nodes. And we have a responsibility. Now some of those patients need surgical management, or some of the patients, if they have a low risk tumor, can be managed with monitoring without surgery. So figuring out where each person falls kind of depends upon their tumor, their anatomy, and their tumor biology.
I'm guessing, because I don't know, that a lymph node resection or a surgery would be a lot less invasive or a lot less of a big deal than actual breast surgery.
It depends upon the extent,
Okay.
But you can do a lymph node biopsy under local anesthetic with sedation, which, at least from an anesthetic perspective, isn't a lot of burden. And it allows you to sort of, there's in the areas where the lymph nodes, there are a lot of other things you may want to avoid. Unlike the breast, where you can easily add more volume to the ablation without concerning that you're going to damage a critical structure. If you're ablating a lymph node in the underarm area, there are large blood vessels.
I'm not even talking about ablating it necessarily. I'm talking about actually the surgical. If you surgically do something with the lymph node, isn't that less of a surgery than doing a breast surgery?
To a large extent, it is.
Like, wouldn't it be simpler? I mean, I know a few people who personally have come to you. They've had their tumor frozen and then did the lymph node surgery separate. Right.
The lymph node surgery is usually just removing kind of, a lymph node from the underarm area. The dissection is limited. We're not taking out extra tissue. So in terms of comprehensive burden, it's less than doing a breast operation where you have to take out the tumor and a margin, and there are potential as cosmetic consequences of that. There are no cosmetic consequences of a lymph node cryoablation. So, but it really comes down to looking at an individual patient, her tumor, her size, and lymph node, and her tumor biology, and then helping her kind of make a decision regarding how best to manage it, weighing the pros and cons of the different approaches.
What's the largest tumor successfully done, and is there a maximum size you're willing to do?
Well, I keep saying there's a maximum size, and I keep being pushed past the maximum size. So I'm sure there is a maximum size. I'm not willing to say what that is, because
basically whoever's interested needs to just contact you and discuss it with you.
Yeah, but it's partly, I mean, I'm not advocating for this, let's be clear.
Right. No,
but usually the people, I've treated tumors that were beyond the limits because the patients were not willing to weren't willing to have surgery. And so I made a judgment that it was better for the patient to ablate her tumor than to allow it to grow because she's not willing to have another treatment approach. Like people that kind of require mastectomy based upon tumor size, maybe it's a multi-center tumor, maybe it's a large tumor. Some will still say, I'm not going to do surgery, even at risk of death. I'm not going to do surgery. And my perspective is that's not an acceptable bargain. There must be another way to help. And so maybe we can use cryoablation as a way to deal with this impending problem, this impending cause of death or this pending ulcerating tumor, and to prevent that. It's not enough treatment. You may still need to have radiation. You may still have medication, but at least you're not stuck at I'm not going to do surgery, therefore I can't do anything else decision tree.
Well, the bottom line is the smaller and the earlier, the better.
Exactly.
Do you have to do a mastectomy, or can cancer be eliminated without it?
Well, obviously we're trying to promote cryoablation as a way, but we're actually kind of in an evolving point. I mean, we always, we started with doing mastectomy for everyone, and then lumpectomy for patients with smaller tumors that did not require mastectomy, with the same long-term survival of those. And now we're using, for patients with larger tumors, preoperative chemotherapy, often to shrink tumors, to make them smaller, to remove, to do a small lumpectomy. And that's kind of where we were mostly in the last 20 years, using preoperative chemotherapy for triple negative and HER2 positive tumors or large tumors, making them smaller, doing a lumpectomy with the same long-term results as someone who required a mastectomy. That's where we were. And so the next frontier is, well, sometimes when we get preoperative chemotherapy, the tumor completely disappears. I mean, there's no detectable tumor left. Do those patients need surgery? At this moment in time, we're still recommending surgery just to make sure there's no disease left. But, there are studies that are looking at doing biopsies of that site to see if we can prove that there's no tumor, and then maybe not doing surgery. We also have the opportunity to do cryoablation in that site and not do surgery. So it really is sort of a kind of an evolving process, which is frankly why I am very interested in one of the main reasons why I'm interested in breast oncology, because it's so dynamic, it's so evolving. We're kind of always trying to figure out how to do this better with less harm. And so, I'm great. I'm happy to participate in that, but I'm also inspired by that when it happens.
When is the criteria to be a candidate for inoperable lymph node involvement for cryo on a slow growing breast cancer? For metastatic breast cancer, but not involving a distant organ.
Okay, I'm not sure I got that.
I know, it's pretty long. Well, the first part is, what's the criteria to be a candidate for an inoperable?
Oh, like if it's a tumor that you can, inoperable, I think that for inoperable lymph node involvement for cryo on slow growing business. Let me do my best to answer that. So, generally, if a patient has a lymph node involvement, I recommend surgical removal of the lymph nodes. The main reason is that by ultrasound and by imaging, you can often see, discrete nodes that are grossly abnormal. But during surgery, when you actually feel the spacing in them, you can often find things that aren't large enough to be seen on imaging, but clearly are abnormal during surgery. And so you can actually do a better lymph node procedure, meaning removing the grossly abnormal nodes and removing the other ones that are left behind. And without surgery, there'd be no reliable way to find them. So my recommendation is usually to start with surgery. Now, some people still refuse surgery. And if they do, then there is a way for us to ablate the obvious ones that we can see by ultrasound, but we don't really address the ones that aren't obvious.
The ones that might be left behind.
Right. And so it is particularly important for those patients, actually for both groups, but it's particularly important for patients with positive nodes to recognize that there may be normal appearing but abnormal nodes remaining, and that cryoblating or removing the grossly abnormal ones is not sufficient. They need something more. Something more can be radiation of the other nodes. Something more can be medication, or both. But that by targeting only the grossly abnormal ones, we're likely leaving some unaddressed ones behind.
I guess the second half is for metastatic breast cancer not involving distant organ, mainly near the lymph nodes.
I think the distinction there would be metastatic to the lymph nodes, because metastatic.
Okay, got it.
So for people with metastatic lymph nodes, I mean, with the story that I just gave is that they're best managed with surgery, but for those that are not willing to have surgery, there is a way to manage it with ablation. But usually you need to supplement the ablation. It's also true, they manage with surgery or ablation, you usually have to supplement it with radiation or medication.
I heard something about it being unsafe to get massages if you're being treated for breast cancer because it can spread the cancer. Is this true?
Well, I mean, we're not necessarily recommending that you massage your breast where there's a diagnosis of cancer already present.
Well, most of the time you go for a massage, they don't massage your breast anyway.
Right, right. So I've
I've
never had that experience, but I mean,
with the exception of lymph node massages. That in that case, it's different.
Right. And presumably the cancer's already been removed. So there's
Right.
not a harm in massaging a breast or
For lymphatic, yeah.
right. If there's already been cancer treatment rendered. But if there's an active tumor that is known to be present, I would suggest that you not massage that because you can displace cells.
But a regular massage that doesn't involve the breast is not an issue, is it?
Is not likely to be an issue.
Okay. How do you treat central necrotic that have fluids alternately? Does that make any sense to you? Do you understand the question?
Well, I can maybe understand the question. So many tumors, as they get larger, they tend to become necrotic in the center, often liquefied in the center. This is mostly for large tumors, meaning like 3 or 4 or 5 centimeters, not 1 or 2 or 3 centimeters. But they become larger because they get so large that the blood supply only goes to the outer part, doesn't really get adequate blood supply to the inner part, and that inner part becomes liquefied. And so, there's not necessarily a specific treatment for that. You can aspirate the fluid, but you really need to deal with the cancer that is surrounding the necrotic portion. So if you're having surgery, we simply remove the whole thing. If you have an ablation, we ablate the whole thing. It still needs to be taken care of as a whole thing. It's just that, some of these tumors are not fully solid tumor cells. They're liquid filled, they're liquid in the center. And it can affect the experience, but not meaning there might be drainage or whatever if it ulcerates. But whether it's surgery or ablation, you treat the same total volume.
I think they were wondering if there's an alternative to it, those things.
I'm not aware of those things. And these tend to be high-grade tumors. They grow so big that they outgrow the central blood supply. So, you usually need to have a definitive breast operation. Generally surgery, but for someone who refuses surgery, ablation is an option. And then maybe something more, depending upon.
With DCIS stage 0, with intermediate grade, do you need an MRI to be treated with cryoablation?
Well, MRI isn't a requirement for any kind of breast cancer therapy. It's often recommended, but it isn't a requirement. So the advantage of MRI is that it helps you sometimes see things that aren't visible on the mammogram or ultrasound. Now, I think probably 80% of the time it doesn't add anything more, but 20% of the time it adds something more, and we change what we do based on that. So that's why we generally recommend it for invasive cancer or DCS, because it may sometimes reveal things that change our operation for the better or change our ablation for the better. So I will recommend it, but if a patient refuses it, I won't necessarily deny the treatment because they refuse it. I would just acknowledge that they are accepting the fact that, there might be things that we don't see, and we're going to focus the treatment based on what we see. But we could have potentially learned something that would have made the procedure more accurate. The tumor by ultrasound might look, or by mammography might look like it's 1.5 centimeters. Maybe MRI would show us actually 2.5 centimeters. And I would potentially change how I give the ablation based upon knowing it's 2.5 versus 1.5.
Could it be that big of a difference?
It could be a lot more.
Wow.
Could be a lot more.
At what point is DCIS too big for cryoablation?
Well, I think it's kind of the same question as the early one. It's now we're conducting a trial, as you know about.
Right.
This is a trial for patients with DCS measuring 2 centimeters or smaller, diagnosed by mammography, ideally with MRI, but not required. And so those are offered cryoablation as a single ablation. That's like the grape example. The ideal patient for cryoablation for invasive cancer or DCS would be one with a grape-sized tumor or smaller, or a DCS size cancer, the size of a grape or smaller. So, there are people that have DCS of larger dimensions that are unwilling to have surgery. I think, if you have a way to target it, I think it makes sense to offer cryoablation. The way that you target it, the main challenge of DCS is that DCS is not usually ultrasound visible. It's usually detected by calcifications or MRI findings. So in order to plan the cryoablation procedure so that you can accurately target the full span of DCS, it is usually necessary to place ultrasound visible markers at the borders of the DCS, so we can know by ultrasound that it extends from here to here and from here to here, so we can target that whole volume.
Are they always a metal? Like titanium
All
or something?
of the markers that are used commercially have, the ultrasound visible markers have a metal part and a non-metal part.
So there's no way to do it where it'll dissolve later and it's gone.
Well, the non-metal part dissolves, but the metal part remains. The metal part is included because it's visible on mammography. And so for follow-up, for surveillance, it is helpful for them to have something on the mammogram that you can confidently say, that's where the cancer was. We have a marker showing its location, if it's been ablated. Or if it was a benign biopsy, that's where we did the biopsy, that's where the thing was. We don't have to worry about that spot anymore, perhaps. So all the markers have a metal part. But there is, for those that may want to use ultrasound to find the site, there are markers, or what we call chips or clips, that have a metal part plus something else. And the one that I prefer to use is one that has kind of a collagen basket in which the metal part sits, because you can see the collagen part by ultrasound. And that part is ultimately absorbed, the metal part remains.
But you can't do it without the metal part?
They don't make them without the metal part.
I'm just being the devil's advocate because everybody,
So-
yeah. Because there are some people that claim that the metal part is actually causing them issues. I haven't had any issues with mine. I think I have one only.
Right, so
but-
it's a pretty rare event. So let me just address it because I think it's important to know. Most people that complain of symptoms at the biopsy site are really experiencing the trauma of the biopsy procedure, not a symptom that's caused by the marker. Because when they biopsy the area, they're taking out multiple pieces of tissue. That area has to heal. It takes months or sometimes even years to heal the area. The marker is just an incidental thing that's there, but sometimes it's blamed for the symptoms. It's not the marker in the vast majority of cases. Now, you should know that markers are made of metal. Some of them are made of titanium, most of them are. Some are made of steel, and then some are made of nickel.
Nickel's bad.
And nickel is
I'm
bad
allergic to nickel.
for people that have allergies to
Yeah.
nickel. So it's important to know if you're having a biopsy done, whether or not, especially if you have a nickel allergy, whether or not the nickel is in the marker, because that is clearly potentially a cause for
You
there
know,
to be issues.
They never asked me that. They didn't even ask me if I wanted the marker. They just kind of put it in and told me they were doing it as they snipped it and it was there.
But it's appropriate for them to let you know. And it's important for them to inquire about nickel allergies if they're using a nickel containing marker. Maybe not if they're using a non-nickel marker, but if they're using a nickel containing
Then maybe
marker.
they didn't.
That's
It hasn't
important.
bothered me, so it's probably not.
Now, I haven't.
Hopefully titanium.
Well, I was going to say, I have encountered a couple of patients that state they have allergies to titanium. So if that is your situation, then anytime you're having a biopsy, you should ask, are you using a titanium containing marker? Because that could be a problem. There are there are markers that contain steel, and I haven't met anyone who's had allergies to steel yet, but I'm sure someone is out there.
Can cryoablation be available therapy for DCIS after a lumpectomy and radiation to stave off reoccurrence?
Well, I don't think that you need to do lumpectomy, radiotherapy, and cryoablation. All three is probably over treatment.
But what if you have a reoccurrence?
But if you have a recurrence, then it's almost like you have a new cancer, meaning it can be treated with a lumpectomy or it could use cryoablation in most cases. If it's a recurrence that's localized and therefore treatable with lumpectomy, it's likely localized enough, like meaning small enough, specific enough to be targeted with cryoablation. And in fact, I've treated quite a number of patients that have had lumpectomy for breast cancer that had a recurrence who opted to have cryoablation.
And it doesn't matter if you've had radiation before.
It doesn't.
Okay, because I think that was part of the question too.
I mean, your risk of recurrence is much higher if you've not had radiation.
Well, I think they were
But if you
concerned with
had it-
everyone, whether you can do it if you've had radiation. Because I think sometimes you can't have plastic surgery after radiation.
Right, it's a little different because with plastic surgery, there's usually tissue mobilization where they're shifting tissue from one place to another. And it requires a lot more blood supply to be able for that to heal.
I think that's why they're asking
Yes.
the question though, probably, my guess.
But there is an issue though. So whenever you have had radiation, the blood supply to that organ is sort of reduced. And so the reason that you can't do a lot of plastic surgery is that you can't move parts around. But you can cryoablate the area. It would be just as effective. The only difference is that you might have more fat necrosis after cryoablating an irradiated breast compared to a non-irradiated breast. Fat necrosis areas where the fat gets liquefied or sometimes forms calcium deposits. But that's just the hazard of doing anything in an area that's been radiated, that the blood supply is compromised. And so the healing is somewhat limited, but it ultimately heals normal, except for maybe having more firmness there or having more calcifications there.
Can you do cryoablation on triple negative?
You can do cryoablation on anything. Now, it's more controversial to do it on triple negatives because in most cases, triple negatives need, surgery or some kind of breast treatment. They need radiation, they need medication, they need lymph node surgery. So because of the need to do kind of all of these things for the triple negative patient, usually they're excluded from cryoablation, which is generally designed for someone that doesn't need all those things. But that said, I mean, if it's a matter of managing the breast tumor, it can be done. I would still recommend a lymph node biopsy because the need to manage the lymph nodes. I still recommend radiation because these tumors have a higher risk of recurrence, and these patients often need chemotherapy as well. So all those other things are still needed, you can do all those other things. It doesn't mean you can't do cryoablation. And in fact, I have treated a number of patients with triple-negative breast cancers to manage their breasts and have encouraged them to do the other things. There's one other approach is that in general, the data show that people with triple-negative breast cancer have better survival if they get chemo, if they're willing to have chemotherapy. The survival is better if they get chemotherapy up front.
Right.
Chemotherapy followed by surgery and radiation, or chemotherapy followed by cryoablation and radiation. So I will always advise them that the evidence shows that their prognosis would be improved if they commit to doing chemotherapy first, and then we can just ablate the site later. If they're unwilling to do radiation, sorry, if they're unwilling to do chemotherapy first, in that situation, I am willing to do the cryoablation up front with the hope that they'll come around to having chemotherapy later.
Isn't it always better, no matter what type it is, to do some chemo or targeted therapy first?
Not really.
No?
It is true.
I
it
was
is-
thinking of it in the sense of to find out if it actually is going to work.
Right. So the data, if you're talking about what does the evidence show? The evidence shows two things: that giving a pre-treatment chemotherapy, like pre-surgery chemotherapy, for triple-negative breast cancers and HER2-positive breast cancers, they're the two where the outcome is better when you give the drug therapy first, followed by the surgical or cryoablation therapy later. For the others, it doesn't make a difference.
Okay.
The others being basically the hormone receptor-positive tumors that are HER2 negative. So it is the standard of care now to do surgery first for hormone receptor-positive tumors that are HER2 negative, as long as the tumor is small enough to be treated with surgery, like with a lumpectomy. Maybe we'll give drugs first if we want to shrink it. It's a big tumor, but it's not because survival is better by giving a drug therapy first. We're just trying to improve the options for surgery. But the trials for triple negative and HER2 positive show an actual survival improvement when you give the systemic therapy up front.
Is cryoablation an option for invasive lobular breast cancer with visible tumors?
It is an option. It is more challenging, but it is an option. So you have to understand the main differences between lobular cancers, invasive lobular cancer, and invasive ductal cancer. Ductal cancers have a protein that causes the cells to stick together. It's called ductal because a tumor is trying to form ducts. And in order to form a duct or tube, they have to kind of join one to the next. And so these tumors tend to be more compact because the cells have the protein that enables them to attach to the next cell. And that's kind of why they tend to be more discrete, more round, easier targets for cryoablation. Lobular cancers don't have that protein. So even though there may be areas where there are cells that are piled up one next to another, they're just really kind of bunched up together. They're not really holding hands. They're not really stuck together. But in addition, there may be many other cells that are set apart from the main mass that aren't connected. And so lobular cancers, on average, tend to be more diffuse because it maybe the same number of cells, but they're spread out over a larger area. And the edges are a little hard to see because it's not a sharp edge of a pile of cells. It might be one or two cells sitting in an area where they kind of blend in better.
It's just harder to do.
So they're technically harder to now. Fortunately, not all lobular cancers are like that. Some lobular cancers are discrete, but there's a much greater proportion of lobular cancers that are diffuse compared to ductal cancers, which are almost always compact. So when the initial trials were designed for cryoablation, we generally excluded the lobular ones because they're the ones for which we're more likely to underestimate the size. Whereas for the ductals, since they're more compact, they're easier to size. Now, if I encounter a patient who has lobular cancer and she's not willing to have surgery, I will offer her cryoablation. But we intentionally treat with, number one, we try to convince her to get an MRI because we're trying to get the best assessment of the size that we can get, even though MRI sometimes underestimates. And then we treat with an even wider margin because we have to accept the fact that even mammogram, ultrasound, and mammography combined may underestimate the size. We have to assume it's bigger than it looks and therefore need to treat with a wider margin than the usual margin that we treat with cryoablation.
Do you use automated breast ultrasound?
I don't. It is a way of performing whole breast ultrasound that kind of doesn't require as much technician time, if you will. So it kind of may work as a screening test in a facility where they just don't have the volume the personnel to do handheld ultrasounds. There's no data that I've seen that show that it's clearly better than physician or technician perform ultrasound. But it is a way, although some people will say that, I've not seen the data that to me is convincing that one is better than the other. The idea is if you're going to do whole breast ultrasound for screening or for cancer detection, you need to look at the whole breast. And that's one way of looking at the whole breast, but a technician can also look at the whole breast and make an assessment.
When I had my first ultrasound after the cryoablation, where I went, I saw an ABUS.
Mhm.
And I asked the technician if I could do that instead of the handheld.
Mhm.
And she said for cryoablation, it doesn't work as well. I don't know if that's true, but that's
Right.
what she told me.
I don't think there's any data. Now that might be their judgment, and
Okay.
I'm fine with respecting their judgment. It's just that there's never been a study of EBUS in cryoablated patients. And so, I think the more direct point is ABUS is best for screening of people that haven't been diagnosed. That's where the data is most clearly present. It's as a screening test, not as a diagnostic test for someone who's been diagnosed and treated for cancer with cryoablation or other means. So as a screening test, it's great. It's an efficient way of doing it that doesn't require a technician. But once you have surgery or interventions where there are all these new kind of things that will appear on
Oh,
ultrasound that are just part of the scar
yeah.
scar from cryoablation or the scar from surgery, it can change the sensitivity of it. And then it ultimately will require.
And it's a machine versus a person,
Yes.
so it can't make judgments.
It can't make judgments. So more likely you need to have a follow-up ultrasound to focus on the area that was seen to be abnormal on the EBUS in that case.
Will MRI without dye show if a tumor has grown back?
Well, I mean, in general, if you're talking about breast cancer detection, it requires a contrast, a dye, a contrast that is used with the MRI. Excuse me. Now, large tumor, can still be seen on MRI to see if it's changed in size, just not very well. One of the reasons that we use MRI is that we're looking for the grossly abnormal thing, but also changes in the pattern of blood flow around it that tells us that even though we don't see a gross tumor there, there's a high enough density of blood vessels there to suggest that there's something actively growing there. So without the contrast, you lose that precision. You can see an obvious big thing. It's just that you lose all the small things. And if you're going to lose all the small things, you just as well do ultrasound, because it'll tell you that, or mammogram will tell you that as well as an MRI without contrast. So the MRI loses its value without contrast.
Is there any other contrast that can be used besides, I think it's gadolinium?
Yeah, I mean, gadolinium is the
Preferred.
the one that we know most about, but all of them, I mean, sorry, let me restate that. It is the name of the metal that's used. There are different formulations of the metal. So there's like Magnavist and Gadavist and.
Well, is there anything other than a metal that can be used?
No, not that I'm aware of.
Okay. People are always concerned about that metal getting to the brain.
Yes, there's legitimate concern. I will just add that, in the hundreds of thousands of cases or maybe millions of cases of MRI being used with contrast in various parts of the body, every year, there's really no linkage between retention of contrast in the brain in any health state. It doesn't cause Alzheimer's, it doesn't cause stroke, it doesn't cause dementia. There's no thing that's been, in all of these cases, there's no thing that's been clearly linked to its presence. Now, there may be these outlier things like people have, but these things are so rare they could be caused by almost anything. But that said, we're sensitive to it because, we haven't demonstrated something now, but maybe in 10 to 15 years, we'll realize something that we didn't recognize now. So we recognize that. So we are not as liberal with its use as we were before. Like if it's being done for a cancer workup, then that's an appropriate risk-benefit balance because you want to treat the cancer adequately so that the patient survives. You're not worried about whether she has an MRI complication 30 years later.
Mhm.
You know, if she's not doesn't survive this cancer, then it won't matter. But if you're using it for screening in a patient that hasn't been diagnosed with cancer yet, we used to recommend it every year. Well, now we're thinking, well, maybe every year isn't right because if there are cumulative effects, maybe giving it every year will produce a result in 15 years that we would rather not see. Maybe we should do it every other year after a time point. So because we recognize that there is at least a theoretical risk, we're trying to be more judicious in its use. But that does not inform how you should manage to work up a real life-threatening problem. The appropriate imaging should be done, I think, because you want to get the best outcome from that diagnosis and treatment so that it never becomes a problem again.
How many reoccurrences come back to the breast versus other locations of the body?
So breast cancer recurrences you're referring to. It's a difficult thing to answer, but I'll do my best. So it depends, first off, on the risk of the tumor. Low-risk tumors are less likely to recur. High-risk tumors are more likely to recur. That's the first thing. Secondly, it depends on what you do in the breast. We're going to take an example of a high-risk tumor. A high-risk tumor has a tendency to occur often because there are things around it that you don't see. Meaning that you've done a lumpectomy or you've done cryoablation and the margins look clear by either method, but there are other precancerous areas around it that just haven't manifested yet, but will likely manifest in the next few years. So in order to maximize the results for high-risk cancer, doing lumpectomy alone or cryoablation alone won't get you there. You need to add radiation to it. You need to have medication. And if you look at the historical trials, not even of the high-risk cancer, but of the average cancers, when women had lumpectomy in one arm of the trial and had lumpectomy plus radiotherapy in the other arm of the trial, these are randomized trials, the cancer recurrence rate was 3 times higher in the group that did not have radiation compared to those that had radiotherapy. So we're recognizing that even in patients with lumpectomy, where the tumors are removed, even in patients with clear margins, because the pathologist has checked the margins, say the margins are clear, those without radiation have a higher risk of recurrence than with. So especially for high-risk cancers, you know, surgery alone and cryoablation alone might not be enough. For low-risk cancers, where there is less likely to be other areas around it, there you have a little bit more latitude. You can say, well, the risk of recurrence with radiation is not reduced so greatly by radiation that you can accept not using radiation to treat it. So the bottom line is that the risk of recurrence in the breast largely depends upon the underlying biology of the tumor and whether it is discrete or if there are areas around it. With cryoablation and with surgery, we try to remove it or treat it with a margin so that we can account for things that might be in the borders. Just sometimes there are things beyond that. And that's why radiation has a place.
Mine didn't come back in the breast, came back in the liver and in the lung. So I think that was their question is it more likely to come back in the breast or somewhere else?
So let me address that.
Yeah.
So again, it depends upon if it's a low-risk tumor or high-risk tumor.
Mine's a high risk.
So high-risk tumors, I've been writing this paper about needle track seeding, just as an aside. And I was trying to make the point in the paper that although some people refuse a needle biopsy, this is a roundabout way to answer the question, but I think maybe you get more out of it. Although some people refuse a needle biopsy for risk of spread, the reality is that most tumors spread before you ever diagnose them, meaning that even when they're very small, even when they're a few millimeters in size, they develop the capacity to spread. And sometimes they've already released cells, or they come in and they already have positive nodes. That's because a tumor went to the nodes before they were ever diagnosed. So the point is, that particularly for high-grade tumors, high-risk tumors, high-grade tumors, there is this tendency to spread early in their inception. Now, you might not see those cells that have spread because they're individual small clusters of cells that may be in other organs. Some of them will grow, some of them may not grow. But at the time that you diagnose the cancer in the breast, there's a significant population of women that already have disease that has already left the breast.
Which is probably what mine was.
Yes. And usually, we try to recommend medications, whether it's chemotherapy or anti-estrogen therapy, to kill those cancer cells that have yet had a chance to grow. They may be there, hopefully we'll never see them, but if they're there, we can get a drug to them that will prevent them from growing. But if the drug doesn't work, or if the drug isn't opted for,
Or not kept taken long enough.
right, then anything that survives will continue to grow. And usually it takes about 2 years for those invisible cells to become large enough to be detected on scans. So that's why, it is true that whether it's a local recurrence, where there may be individual cells around the tumor that we don't see, or distant recurrence, where there may be individual cells or cell clusters in the liver or bone or lung, it usually takes about 2 to 3 years for them to become detectable. And so most recurrences of breast cancer in the breast or distant recurrences would typically appear within that first 2 to 3 years, not because it left the cancer at the time that the cancer was being removed, or at the time the biopsy was being done, or at the time that the cancer was being ablated, and it already left. It just took it that long to grow. And it wasn't killed off by the drugs that we intended to give or by the radiation that we gave.
Doctors want us to do breast scans, but what's the likelihood of it coming back to the breast versus liver lung? We just did that. So their question is, why the heck aren't they doing full body scans, given that?
Well, the truth is that things are just too small to see. We're talking about, microscopic things that might take a year or two to even become large enough to detect. And so the reason that we don't do exhaustive scans is that most times the scans are negative, and many times the scans reveal things that are unimportant. Like, oh, there's now something in the liver that's completely unrelated to breast cancer that you've had for 30 years, but now we see it. Now there's worry. Maybe we should do a biopsy of it, and it has nothing to do with the cancer diagnosis, because truly the cancer cells may be right next door, but they're too small to see. So the studies that have looked at using intensive screening for patients, this is actually, it has been studied, looking at intensive follow-up versus symptom-based follow-up. Like, we do scans if the patient develops abnormal labs or if she develops symptoms. When you look at the outcome of those two groups, the survival was the same. The group that had intensive scans were diagnosed a little bit earlier, but they had more procedures, some of which weren't appropriate. But there was no difference in their survival. The treatment started a little bit earlier, but their ultimate survival was not significantly changed. So because of that, and it's been looked at in randomized trials, because of that, it was basically concluded that, symptom-based screening is appropriate, not exhaustive screening, especially for early stage breast cancer. For advanced stage breast cancer, those patients weren't studied in this trial, but for patients with basically stage 1 and stage 2 breast cancer who had no reason to think that there was this disease, if they were screened intensively, it only added more procedures, not better survival.
Is that true too, though, for the high risk ones?
Well, I'm talking about high risk stage 1 and stage 2, as opposed to stage 3 and stage 4. That study has not been done in stage 3 and stage 4 breast cancer patients.
Mine was stage 1 too.
Right. So the studies would have said that it was not appropriate for you to have intensive screening because chances are it was not detectable when, in your first year. Even though it was there, it was not detectable. It's just the limitations of screening. You just can't see things that are so small.
Well, mine actually was a shoulder pain that sent me for the ultrasound that found the spots.
So symptom-based.
It was
screen.
symptom-based.
Yes.
The funny part was, though, the symptom was only there that week. It's
Mhm.
not been there since, and it wasn't there before.
Thank
It was
goodness for
almost
that
like a God thing that, you know, it happened because is
And so
full,
what we don't know is if you had gone for a scan 6 months earlier, if it would have changed the overall trajectory. Like maybe your tumors would
Yeah.
have been found a little smaller. Maybe there would have been fewer ones, but that doesn't mean that they weren't.
a year
there.
before, it didn't show up on an ultrasound.
So
So it's somehow somewhere in that year, because I'd had an ultrasound the year before because they thought because I have fatty liver
mhm.
and there wasn't anything there. But maybe it's too bad I didn't have one 6 months later.
The
but-
operative term was show up. It was
Yeah, it
like
didn't show, well, yeah, it
it
didn't
just
show up.
wasn't visible.
Yeah, there was nothing there.
Yes.
There was nothing to be seen.
Yes.
Is full strength iodine, I don't know if you can answer this one. Is full strength iodine 1 drop directly placed on the breast per day, alternating breast help prevent breast cancer?
I think we'll have to save that one for Dr. Gama.
Yes,
But I will say that, iodine is the risk of breast cancer is connected to iodine, like thyroid cancer, just
Right.
oddly. So it's more kind of making sure you're not deficient in iodine. I don't know if supplementation, like taking extra iodine, reduces your risk. But having inadequate iodine might be more of the problem. But again, I'm not knowledgeable enough about.
I wondered too about iron, if iron has anything to do with it. I'd love to see a study of how many anemic people get breast cancer.
I don't have any data on
It'd
that.
be interesting though. What is your opinion on liquid biopsy for detecting cancer, specifically breast cancer?
Well, that's actually a good question because I recently looked at that. I actually have been writing this paper. I actually finished the paper. I was working on the references last night for it to be submitted because the paper was basically inspired by a number of things I've heard where people are kind of delaying biopsies because of fear of tumor spread caused by the biopsy. And so I had 2 questions I was trying to ask. What data currently exist for the connection between biopsies and tumor spread? Is there any data to say that that's a legitimate concern? And number 2, what are the alternatives? Like, are there ways of either reducing the risk of the biopsy procedure or of not doing a biopsy, maybe doing a blood draw as a way of, which is a liquid biopsy, which is a way of seeing if we can detect cancer by that means. And so I did address liquid biopsy in the paper. The take-home message is that it's not sensitive enough for detection of early stage breast cancer, stage 1 and stage 2 breast cancer. So you can have a cancer, the test is just not sensitive enough to find it. It is more useful if you have advanced cancer where you're more likely to have tumor cells circulating, and therefore the test can be done to sort of see where you are now and see if you go up or down.
Kind of like Signatura?
Yes. But as a screening test for breast cancer is not ready for prime time. It is not sensitive enough to find cancer. And therefore it can't replace a needle biopsy as a way of diagnosing the cancer. So it's used now for advanced stage, is used for diagnosed patients that are being followed, but not as a screening test for breast cancer. There are other types of kind of commercial liquid biopsies that have shown some promise for detecting cancers in the blood, but it's least sensitive for breast. It's more useful for like pancreatic cancer, liver cancers, other rare cancers, but not for breast cancer.
Still evolving.
Still evolving.
One thing I'm wondering about is if you can use cryo on fat necrosis, or would that further damage the circulation and the tissues in that area? Interesting.
It would only cause more fat necrosis. It wouldn't solve it. Because fat necrosis is a manifestation of tissue injury. So whenever fat is injured by surgery, by cryoablation, by radiation, fat necrosis is one way that it heals. And fat necrosis can be either radiographic, where we just see it on an imaging, but it doesn't have any symptoms. Like it could be calcifications. It could be like an eggshell of calcifications. It could be little specks of calcifications. Usually these
Can
are,
you feel it?
well, at one end of the spectrum, you just see it on imaging. You don't feel it. And then at the other end of the spectrum, it can be a firm mass or heart mass. Sometimes it can be harder than the cancer because it's just either all calcium, like a stone almost, or it could be like they call them oil cysts, like a cyst, but it's instead of being filled with water, it's liquefied fat. These are ways that fat heals from injury. We call that fat necrosis. And anything that causes more trauma, like surgery or more radiation or cryoablation, can cause that area to have more fat necrosis, because fat necrosis comes because the blood supply wasn't good enough in that spot for it to heal. Therefore, anything more you do to manipulate it or traumatize it can make fat necrosis more prominent.
I would love to hear what you wish conventional breast oncologists knew about their cryoablation patients in order to give them the best post-cryo care. Things to watch for, things not to be alarmed about in their patients.
Well, I'm trying to address that, as you know. I've been working on this paper, which is finished. There are two versions. There's a short version. I think I posted about it the other day. There's a short version and there's a long version, because the long version was too large to publish. But the long version and short version, neither of them will address kind of most of the consideration that should be given to the patient pre and post cryoablation. The main concern being that, cryoablation patients often need radiation, and so radiation oncologists need to understand how to utilize radiation to treat such patients. Patients that have cryoablation often need systemic therapy, and so medical oncologists need to understand how to integrate how cryoablation fits into, they're not competitive, and how you make them work together. And so recognizing that there was such a lack of knowledge in that area, I decided to write this guideline. In fact, when I really thought about it, I said, there's a standard of care for how you treat a patient that has had lumpectomy, but there's no standard of care for how you treat a patient with cryoablation. Is everything the same, or are there differences? And so, I've been doing this now for 2 decades. I haven't had a chance to at least think about sort of the various considerations from a drug therapy perspective, from a radiation therapy perspective, from a following imaging perspective. And I decided to write this guide. It's not truly a guideline. Guidelines are usually kind of more like a group of people get together and develop them. But I decided that I would take the first
It's your
pass
recommendations.
at defining the things that should be addressed in the guideline. The guideline that will someday emerge. All the things that need to be addressed that would allow us to manage patients today, not like what we're going to do about them in the future. And now, there are all these clinical trials, not all, there are clinical trials for treating breast cancer with cryoablation, like the DCS trial. There's an active invasive cancer trial at Washington University. There's this trial that I think I'll probably be leading for lumpectomy compared to cryoablation. And all of them say, we're doing cryoablation of the breast and radiation and systemic therapy according to standard of care. It's like, well, there's no standard of care. I mean, there's standard of care for lumpectomy,
Right.
but when the medical oncologist sees a lumpectomy patient, or your radiation oncologist when your medical oncologist sees a cryoablation patient, or when the radiation oncologist sees the cryoablation patient, they scratch their head because they don't know what to do. The standard of care doesn't translate for them. I'm trying to help it translate.
Which is why a lot of them want nothing to do with it.
Right. Or they say, I can't treat you because you haven't had your tumor removed. I don't know what to do with you now. For radiation patients, we always give radiation after the tumor is removed. I have no guidance on what to do when the tumor hasn't been removed. So we have to give them guidance, a way to think about this.
Well, why don't you just publish your long version as a book?
I mean, maybe one day. It's not long enough to be a book, be a booklet. But I am publishing the short version, and then the long version will be a supplement that you can download. So in the publication, there will be a link for the long, and so it'll be available to anyone around the world who wants it. They don't have to buy the book.
By the way, is the DCIS trial still enrolling?
Yes.
So therefore, anybody with less than 2 centimeters DCIS that's interested should
Please.
look into it.
Please.
How do you best monitor for invasive after low risk DCIS long-term strategy?
So how do you manage for invasive cancer recurrence? after DCIS. So DCIS treated with cryoablation, I take it?
I guess,
Okay.
or maybe cryoablation and lumpectomy.
Okay. So in general, DCIS is most often just diagnosed by based on the presence of calcium deposits. Not everyone is diagnosed with that, but for most patients that have screening mammograms, their DCIS is found because it presented with calcium deposits. With calcium deposits being the earliest indication of DCIS, the most way to screen for that, the most appropriate way to screen for recurrence is to use mammography, because likely it will appear as an invasive, sorry, as new calcifications in the breast. Now, sometimes it appears as invasive cancer, but still more of those patients will have DCIS as either the DCIS recurrence or the DCIS step before it becomes invasive cancer. So in mammography, take-home message is mammography is important. Now, some people have DCIS that was found incidentally on an MRI, meaning that they didn't have calcifications or a mass, but maybe they had screening MRI, they had MRI for another reason. And so their DCIS was only MRI visible, not visible by another study. In that case, MRI would be more important for screening because that was the way that it was found. But that's kind of the exception to the rule. Most people have DCIS that was detectable with mammography. And so mammography is the most important way to screen.
Do you really need it every year?
Well, that's a different question. I think, knowing what you know about the natural history, the recurrence rate is highest in the first 3 years. So if you're going to screen regularly, yearly, it makes more sense to screen in that first 3 to 5 year period on a yearly basis. I think after that, you can make an argument for screening less often.
Because it is radiation.
It is radiation, yes. It's a small amount, but it's not completely insignificant. So, we don't say screen every 6 months,
Well, I'm just bringing it up because a lot of ladies have a concern they don't want to do it because of the radiation.
Yeah, I think they have to find, everything in life is nuanced and requires trade-offs. You're weighing a pro against a con. And, a major con is that you can find the cancer earlier. A pro is maybe you have a little bit too much radiation. Maybe it can be a problem that'll manifest over the next 10 years. So you have to find the right balance. And so the balance might be, okay, I will agree to screen yearly for the next 5 years, but then after that, I'm going to go to every other year, every 3 years, because that deals with the present problem. That is the greatest risk to them. The fact that they're more likely to have a recurrence now, as opposed to 8 or 10 years from now.
I skipped a year. I wonder if it made a difference. Because I skipped a year, not intentionally, I just didn't get around to it. And then I had a discharge and then I went and that's when they found the cancer.
I think on an individual basis, it probably can matter. But if you think of like population screening, out of 100 women who skipping a year matter on average to those that don't skip a year. Probably not much, but for the individual who actually has a cancer, because,
So mine was really small.
Yes.
It was still under 2 centimeters.
Right. So probably didn't make a significant difference.
Does cryoablation affect lymphocytes and or neutrophil biomarkers? Since your body has to break down the mass, would there be an inflammation biomarker that would be affected?
Well, I am not aware of any commercially available biomarkers that are used to look at response to treatments. I know it can be done in like as part of a scientific study, but I'm not aware of any. It's a conception, it's a concept, but it's a concept that doesn't, there's no way that's nothing to do with it. Now, if you're asking the question differently, does cryoablation cause a change in your lymphocyte or white blood cell profile? There's clear evidence that it happens in the breast. And we don't know if that's enough to cause any benefit, but we definitely know that it causes changes in the breast. I don't know if those changes are clearly detectable in the bloodstream. It's not been done in human studies of breast cancer. It has been looked at in animal studies, but we really should be talking about human studies, not animal studies.
I'd be interested in learning your opinion on how women can reduce fibrocystic breast symptoms. What do you believe about thermography, and if you find more success healing cancer with or without surgery?
There's several questions in that question. I'm not quite sure how to answer all of them, but I'll answer one of them. Fibrocystic changes is a condition that is present in to some degree in most women. It basically is a description of how the breast ducts age as you get older. I mean, initially they are active and they're preparing to make milk, and eventually after menopause, that purpose is lost. And so sometimes they become kind of cystically dilated. We call it a cyst, where the ends, instead of making milk, they just kind of mix water and the water forms a sac. It happens at all ages, where a duct might die in that way, or sort of become retired, if you will, no longer actively engaged in the menstrual cycle. But for some people, this becomes quite a prominent condition. They have many cysts, they have many lumps, and we call that a fibrocystic change or condition. But even people have, at a microscopic level, when we do a biopsy, we often find fibrocystic changes, because it's just a feature of how the breast ages. Sometimes it ages with things you can feel, sometimes it ages with things you can't feel. Now, there is also sometimes a tendency for the breast to hold on to liquid, form cysts. And sometimes that's related to lifestyle and dietary considerations. For example, caffeine intake causes some retention of fluid in the breast, can cause fibrocystic breasts to be more tender. That's kind of something you can treat by reducing your caffeine intake. People that with symptomatic fibrocystic breasts, they usually call fibrocystic breast because they're symptomatic, not because there's fibrocystic changes. And so often the thing that improves the symptoms of that breast is to reduce caffeine or to replace some of the nutrients that are deficient in the breast. Iodine might be one of them, for example, but it's often a free fatty acid. It's a type of acid that you would normally take in your diet, but might be deficient. So if you've ever heard of people taking primrose oil for management of breast pain, primrose oil has a fat in it that is given to replace some of the deficient fat in the breast that is linked to breast pain. So when patients come to me with chronic breast pain, with no other underlying problem, no cancer, if their primary complaint is breast pain, whether one breast or both breasts, then my recommendation usually, number one, stop caffeine. Number two, take a primrose oil for 3 months. Requires a 3-month course and a higher dose than what you normally get over the counter. And also to supplement it with, you can take flaxseed oil. Flaxseed oil does the same thing. And I also recommend vitamin E, which also helps. So fibrocystic condition as a thing is only important for people that have symptoms. And we manage the symptoms with these things that improve the health of the breast.
Got that one. I was told by my surgeon that there's no such thing as a cancer stem cell. With my personal research and speaking to numerous naturopathic and integrative doctors, they said there is indeed cancer stem cells. What's your opinion?
There's no question. There are indeed cancer stem cells. It is estimated that some fraction of a percent of tumors in a cancer are stem cells. They're the cells that actually are most active at producing more cells. And they also are the most resistant subpopulation. Like when given chemotherapy or we're given radiotherapy, for example, they're the most resistant, not saying that they're completely resistant, but they're more resistant than the daughter cells, if you will, those cells that are
They're
made
the harder ones to kill.
The harder ones to kill. So, with surgery, we remove them in the breast. With ablation, we ablate them. We can kill them with ablation. But it's one reason why sometimes if you're only treating with drug therapy and you're not actually removing the stem cell, that the cell cancer grows back, because there's this kind of resistant subpopulation that regrows. So I would just say that person just doesn't know that there's a clear body of evidence to say that stem cells are real, they're distinct, they're harder to treat, but They can be treated. And in fact, there are a number of trials that are looking at kind of stem cell signatures, so they can have drugs that target certain characteristics that are unique to stem cells.
I think good. Regarding stem cell seed, how can it be known whether the stem cell is no longer a concern? I had a lumpectomy. Path lab showed that the borders were clear. No further allopathic treatment was done. What's the most accurate test to make sure this determination, or is there one?
No, I don't think you can really know that. I mean, if you had a lumpectomy and the tumor were completely removed, then the stem cell of that tumor was removed. Now, it doesn't mean you don't have other stem cells. And in fact, the reason that we give radiation and medication is that we know that tumors aren't always unifocal. They're often multifocal. They're basically seeds, if you will, that are not detectable, that are present in the perimeter. They're part of the underlying condition that need treatment. So even though you remove the visible tumor, there are these stem cells in other tumor foci or spots that will give rise to a new tumor without any treatment. So there's no way to know for sure. I mean, of course, you can treat every breast with a mastectomy, and that would at least deal with stem cells that are in the breast, but that's kind of overtreatment. We try to address that by doing lumpectomy or cryoablation with a margin, and then adding additional therapy, medication or radiotherapy, so that every woman doesn't have to have a mastectomy to manage their breast cancer.
Going back to DCIS, is so many doctors that if somebody has DCIS, they want a mastectomy. Why do they? I mean, I guess one of the questions in the DCIS groups all the time is, why are these doctors saying that you need a mastectomy when it's not an invasive cancer yet? So why not do other things first? Or does it depend on the extent of the DCIS?
Well, I mean, it should depend on the extent of DCIS. I mean, there are places where mastectomy seems to be the most reasonable answer. If you have, DCIS that involves half of the breast or most of the breast or a large part of the breast, so that if you were to remove it, you would have not.
It would basically almost be a mistectomy.
Or produce a very poor cosmetic result. So that in that scenario, mastectomy kind of makes sense, but most people have much smaller disease, and so what I've heard is, or maybe I'm just thinking, is that some people may say you should do mastectomy because it might prevent you from ever developing invasive cancer. It's almost like a preventive procedure.
But you can get cancer even if you've had a mastectomy.
You can. But I'm just trying to explain why they're thinking. So sometimes it's best to overtreat so you don't have to deal with a lower chance. But the reality is that, most people have disease that's small that can be treated without having a subsequent cancer or having it impact their lifespan. So I think that, it is certainly shouldn't be the view that most people with DCIS should have a mastectomy. They should be the people that, in general, should be protected from having mastectomies if they're small, because they have a treatable, curable problem, as opposed to people that have extensive disease. But I think some providers sort of kind of overreact by using mastectomy as kind of a preventive, as a way of making it a preventive thing.
What about the wait and see? Isn't there a large percentage of DCIS that doesn't get any worse?
I think they all are. You have a spectrum of disease. And so I think the most important thing is to just not look at it as one disease, and not just look at the patient as one patient. You have various manifestations of disease. You have various patients that are more or less aggressive with how they want to manage it. And so you have to find the right blend. Certainly there are people with extensive disease that require more, but if you don't have a situation that requires a mastectomy, then you have to look at, the size. You have to look at the biology. Is it a high-grade DCIS versus low-grade DCIS? Look at the patient's age. Is she a young woman with high-grade DCIS or low-grade DCIS? Is she an old woman with it? Because the aggressiveness might vary. Is she someone who would want to have mastectomy for any size DCIS? Or is she someone who wants to do her best to preserve her breasts, even if it is a larger size. And so all of these are factors you have to incorporate into decision about a patient. And hopefully, most patients will be somewhere in the middle. They have manageable DCS, they have a manageable problem with surgery, they don't require mastectomy. We just have to give them more manageable options. And so those manageable options includes expected management for lower risk disease, includes cryoablation or lumpectomy for smaller areas of disease, and includes, plus or minus medication, or for some mastectomy. But I think most people can find something in the middle. We just have to give them some options that work for them.
You just have to find a doctor you're comfortable with that'll listen to you and that you can dialogue with.
Yes.
Rather than one who says, this is the way it should be, and you're going to do what I tell you, or I'm not going to treat you.
Yeah, I've never used those words.
There are some that do, though.
Yes, I've never used those combination of words. I have said before, I cannot treat you for different reasons, but I'm not used, it's kind of my way or the highway rule. It's because, as a physician, we all start by learning rules, but we all have to find a way to apply the rules to the real world, because not every patient fits the rules. And that means, using judgment, not just science, to help a patient, help care for a patient. That's I use the terms of care as opposed to treat, because recognizing kind of where they are, what they will have done, and help them find a way that preserves the health as much as possible, given the parameters you're working with.
Why is stage 4 breast cancer considered not curable?
Well, there are probably some cures that do happen, but in general, the concern is that, most patients with stage 4 breast cancer end up having a chronic lifelong disease. Now, hopefully that's a very long lifelong disease, but sometimes it's not. But it's not a situation where you can get to the point that you're confident that the disease has been completely eliminated. In that sense, it's like diabetes and hypertension. It's a chronic lifelong disease that's manageable. You hopefully can manage it in a way that you have longevity, but for many people, it's not achievable, and it just depends on how effective the therapies is, which is true for medication, for diabetes and hypertension. It depends on how effective the therapy is. You were saying?
I was going to say, I'm going to throw a wrench in that. I was a type 2 diabetic, and I had high blood pressure. I no longer have either one.
Right, because of some things that you did, and which I'm using that as a general principle, that most people don't have their condition cured. They find a way to manage it. And so I think you manage it in the particular ways that you did not require drugs, but it required management, right?
Well, I was on drugs. I got off the drugs.
But you then manage it by managing your diet, managing your fitness, and managing other factors.
I guess I don't even think about it. It just it isn't there anymore.
But that actually gets to the point of it that, there are these chronic conditions that we manage medically or non-medically, because they're always looming and can be, they can get worse if you don't take certain considerations. So breast cancer is not exactly like that, but there are similarities when it comes to stage 4 breast cancer or stage 4 cancers, is that, the long-term success depends upon the ability to manage it. And there are just fewer options to manage it. So some cancers are more easily managed, some cancers are much more difficult to manage, but we don't generally consider it a curable situation where it never has to be managed, because in a case of breast cancer, there may be actively growing cells that you can kill or remove or ablate, but there are inactively growing cells that may become active again once something changes, because of stress or because of diet or because of immune system changes. Things that might not be actively growing may grow, or things that might not be actively growing because they're responding to the medication may develop a mutation and then start to grow again. So that's kind of why it requires, it's not a curable situation. You just intended for it to be a chronically manageable situation.
Here's a loaded question, but the ladies ask all the time, why you can't take insurance for cryoablation? You've explained it to me,
I've
explain it
explained
to them.
Well, how do I approach this? The different aspects of it. So, in insurance, there is a professional fee for things and there's a technical fee for things. And so providers, if we're doing it in our office, we would bill for technical and professional. If we're doing it in the hospital, then we bill for professional and the hospital bill for technical. And every procedure, whether we're doing lumpectomy or cryoablation, has a code. And the code was developed to reflect the work effort so that the amount that you get for the payment covers the cost of the work. So as you know, there is not yet a professional code for breast
It's
cancer.
a trial code or something.
Right, there's called a category, the category 1 code is the official code. A category 3 code is an accounting code. Official meaning that it's an official code that says this procedure is worth this amount, therefore you can bill this amount for it. An accounting code, a category 3 code, is a code that says there is this new procedure that is interested in getting a category 1 code. We don't know if it's even worth the effort to get it, but before we can get to the point of giving it a value, let's at least track how often it's used. And then once we realize someone is coming through, once we realize it's happening enough, then we can start the act of Congress to get literally, I'm not joking, the act of Congress to get a value assigned to it. And until that happens, you can bill for it, but the insurance company will pay you what they feel they want to pay, or they can pay nothing. And that's just too great a risk for a practice that's trying to do it, because I have to pay for equipment, I have to pay for supplies, I have to pay for staff, I have to pay for insurance, I have all of the expenses of providing the business without the guarantee of payment, right? Secondly, there is also a contractual relationship that we have with health plans. So if I say accept United Healthcare, just using an example, United Health says you have to accept the payments that we give you for, you can't balance bill a patient. And so, especially true for Medicare, you can't balance bill a patient. It's a violation of the contract. So I either have to accept what they pay, or I have to not offer cryoablation, or I have to do what I do, which is I have a separate practice that's not contracted with any health plan that allows me to do business and not be bound by the constraints of the health plan.
Which if you were, that you wouldn't be offering it. Right.
I could not. In fact, as you know, I recently had to raise prices because, I sort of figured out the cost of it. And they realized, oh, I never even factored in the fact that I have to pay taxes on the month. So I actually was losing money initially, but I had to adjust the price so it at least reflected the real cost of doing business. So now this is an evolving thing. There's now a category 3 technical code for hospitals to bill, so they can actually bill now. You can bill a category 3 professional code, it's just that you may get paid $100 for it or nothing. The other limitation is that the code that exists now, that is now used for Medicare patients, says that this is a treatment that's approved for treatment of one site in the breast that's 50 millimeters or smaller, that's luminal A, meaning low risk tumor, hormone receptor positive, HER2 negative. So it's a very narrow group of patients for whom this code applies. It also means you're only going to get one payment for one treatment, whatever that treatment is. You'll only get paid to treat one site in the breast, even if you treat 4 or 5 ablations. You only get one payment. So there are lots of kind of realistic, sort of pragmatic issues that doesn't allow me to offer it.
The point is, you just can't do it at this point in time.
Right. At some point there will be.
I was fortunate. I self-billed it after the fact.
Mm-hmm.
The first initial one got denied. I appealed it and I got paid what it would have been for one tumor, but I had 2.
Right. And many
so it worked out in my case to be like 50%, because it was 80% of the one tumor.
Well, we do provide patients documentation to verify that they've had it. And I have heard some have gotten full and reimbursement from their health plan. We said, this is what we charge, and some have gotten full, or some got partial, but they can get something back for the procedure.
They might have to fight for it.
They might have to fight for it, but we just can't offer it outside of a trial. For people who participate in the DCS trial, they get it for free. There's no cost to them. But for those that are not in the trial, we just can't take that risk. Now, just to complete the story, the way that the process goes and why it's kind of complicated is that, whenever there's a new procedure, whenever there's a new procedure, like there's new cryoablation procedure, well, the government says, the process of giving it a value, saying, okay, we're going to pay $5,000 for that procedure. They don't say, oh, let's go to our bank of money and just put monies on the table for this cryoablation procedure. We'll say, well, we're funding mastectomy, we're funding lumpectomy, we're funding lymph node biopsy. So in order for us to make money for the lumpectomy, for the cryoablation procedure, we have to take some dollars from mastectomy, we have to take some dollars from lumpectomy, we have to take some dollars from lymph node biopsy in order to make dollars available for cryoablation. So it actually is a pretty political process of how much, because it's, there's a fixed pot of money and it's getting smaller. So when you create a new procedure and you say, well, this procedure takes twice as long as that procedure, then they're going to pull money from that procedure or another procedure to assign value.
Isn't it cheaper to do a cryo than a lumpectomy or a mastectomy?
It doesn't matter. I mean, it matters. It matters. But in terms of how decisions are made for funding the procedure, it actually, that professional code that we all want will come from a survey of surgeons that do cryoablation who will quantify, I spend this much time doing mastectomy, I do this much time doing lumpectomy, I do this much time doing lymph node biopsy, I do this much time doing cryoablation, and they're gonna balance the work effort.
So part of the problem is you don't have a whole lot of surgeons doing it either.
Yes. So why go through that whole political process of reducing reimbursements for every surgeon that does a mastectomy for the few that do cryoablation? Because the money comes from them, essentially. Right. So the process, the hazing process, if you will, is they create a code, say, okay, we're going to have a code to at least track what's being done. And then once we've seen that there's like 15,000 cryoablation procedures done or some number, we're going to say now it's worth taking on this for the entire general surgery community, because our effort to give it a value would challenge every mastectomy reimbursement that currently exists across the country. So it's a highly political.
So a lot of it is convincing the surgeons to do it too.
Yeah. So and part of it, that is, growing the experience, making sure that more of them can do it. Some of it's generational because there are a lot of older surgeons that don't have ultrasound skills, the younger ones that do. So, but that's kind of why it's so hard.
Well, I just thought that it would be good for them to understand why.
We're starting to share the politics.
It's very frustrating to people.
Well, we don't normally share the politics, but you kind of have to know in order to understand why there's frustration, but why these things take time. That's kind of why it takes time. Sorry to end on that political note, but that is, so advocacy helps, but to kind of motivate the societies to embrace it. But it takes time. So we're actually now at 3:30.
Yeah.
Thank you for your time.
I just want to say one thing that has nothing to do with any of that, but so many of the ladies are all concerned about my condition and how come I gave in and I'm doing a chemo now and all this. But you get to the point where you've got to make a choice. This is where you're at, and how am I going to fix it? And fortunately, you got me a really good oncologist who was with us the last time, and she was sensitive to what I wanted and what I didn't want and how I felt. And she picked a treatment for me that's been very tolerable. It's not without side effects. It's affecting my hands and my feet and some neuropathy and bloody noses and runny noses and but it's tolerable. I'm exhausted, but it could be a lot worse. And so I just think that everybody needs to find somebody that can work with them and help them in the right way. And that, sometimes it's got to be integrative. It's not just black or white. I have an integrative MD who totally approved of what Dr. Chap picked. So you just have to find the right team that you can work with and research it all and look at your options. And I don't want to I plan to be around for a long time, so I'm going to do what I have to do.
But thanks for being open. It is open to it and at least drawing attention to the need to find a provider who's willing to meet you where you are and work with you from there.
Well, all these wonderful Facebook ladies have been very supportive of me and very caring. And I feel like I need to be open because I think it helps them to see that you have to be somewhat open-minded to survive all this.
Well, hopefully, we're intending this to be a successful endeavor.
Well, the best thing she told me was the first time I saw her, she goes, I have a patient who's been on Herceptin for 25 years and she's doing fine.
She's not coming up.
So at least she was positive, you need positive input. If you get an oncologist like the first one I had, who's very negative and just tells you, you're not careable anymore, blah, blah, blah. You don't want that. You want somebody who's positive and you feel like they're on your side, because a lot of it is state of mind. And what your mind thinks can make a big difference in how you are.
It's important to be optimistic as you are. And sometimes you're optimistic and you have no options. Sometimes you're optimistic and you have really good options. And I think you're, blessed really to,
I feel extremely blessed. I have you.
Yes. Well, you have a whole community of people.
Yeah, I do.
And I'm just,
But I have been like blessed beyond belief. That's how I feel. And the people that say to me, don't you wish you didn't get the cancer? How can I wish I didn't get it when my life is so much better now with it? Yeah, I got this every 3 weeks infusion and these pills I got to take that I hopefully get off in a couple of months. But other than that, the life is so much richer. I could just be this old person, retired, bored, and I'm not.
Well, you've made my life more interesting. But most people don't have such a clear choice: get a cancer or not. And often people get it, and they, they can't change the circumstances of the diagnosis, but it can change the circumstances of the experience.
And nobody else in my family had it. I never, in my wildest dreams, thought I would ever get breast cancer.
And here you
And
are.
then I really didn't expect it to metastasize. But after the HER2 webinar, it's always been in the back of my mind, when is this going to happen? Is this going to happen? But
well, hopefully others have heard of it. And I just, frankly, so pleased that it is a very manageable one, for which the options are expanding. So, you have Herceptin, you have, several different alternatives.
I still got my hair.
You still have your hair.
In fact, I'm growing a lot more and I can't figure out why. So, yeah.
Interesting.
Yeah, it is interesting.
You have to think about that. Maybe you have something that everyone wants. You don't want the diagnosis.
Rosemary oil in my hair, in my shampoo. But
well, thanks for this extra few minutes of sharing your own experience. You're always welcome to do that. And thank you all for listening. So we'll meet again. We've been at every other month schedule. So we'll set a date and share it with you. Thanks for your time and your trust and your questions. And thanks for your leadership and advocacy. All right. Have a good day. See you next time.